Welcome to our new bariatric surgery patient medical education class. The intent of this class is to educate you about how to pick the right bariatric procedure for you. Here's our team, who will work with you before and after surgery.
Let me introduce you to Amanda. You're just meeting her for the first time, but chances are you're already making assumptions about how much she eats and how little she exercises because she's obese. But I'm about to show you that there's much more than meets the eye when it comes to obesity. There are lots of Amandas out there and they need treatment. Maybe you're one of them, or maybe you know an Amanda. It's time to act on obesity. But in order to do so effectively, we need to understand obesity. It's generally accepted that body weight is determined by a pretty simple formula. We call it the energy balance equation, and it works like this. If the number of calories that you consume equals the number of calories that you burn, your weight remains the same. If you consume more than you burn, you gain weight. And if you burn more than you consume, you lose weight. Most people think that those of us who properly manage our energy balance remain lean, whereas those of us, like Amanda, who eat too much and exercise too little, become obese. We view obesity as a lifestyle choice, and the cure for it is simple: eat less and exercise more. This may sound logical, but it's wrong. Let me explain. First, let's talk about set point. No, I'm not talking about the point in a tennis match when one player is about to beat the other. I'm talking about a theory that says that no matter what you consciously want your weight to be, your brain has its own sense of how much body fat it should have on board, and it has a complex system in place that very precisely regulates your energy intake and expenditure to keep you within a so-called set point range for body fat. So that whole energy balance equation, it's not something that you control voluntarily. Your brain regulates your calories in to your calories out for you. For your brain to do this, it needs to know how much energy you have on board at all times. And it knows this by listening to hormones like leptin, which is made in your body fat. You can think of it like a car. Leptin is the gas gauge that tells your brain how much gas is in your tank. But leptin is just one piece of the puzzle. You've got a whole bunch of other hormonal signals and sensors that are involved too. Your bones, muscles, pancreas, liver, GI tract and sensory organs, they all play a role, communicating with your brain to give it the information it needs to do its job. But that's more detail than we need for this conversation. The point is that you have a complex system in place that regulates you to within a set point range for body fat. So what happens if Amanda decides to lose weight by going on a diet? After all, people with obesity should eat less, right? Here's what happens. She loses weight, but her hormone levels change. Her brain hears this, and it starts acting to restore whatever body fat she's lost. She feels hungrier, and although she doesn't know it, she's also burning fewer calories than before. You see, set point is usually a one-way street. Once it's been elevated, the brain works to defend it just as vigorously as it would a lower set point. Amanda's brain doesn't know that she needs to lose weight. It only knows to defend her current set point. Back to our car analogy. Amanda can't help but look for a gas station to refuel when she sees that her gas gauge is low. At the same time, she becomes more fuel efficient, burning less energy than before. This might explain why treating obesity with diet and exercise so often fails to produce the desired results. It's sort of like telling Amanda that she needs to be a more careful driver, when the real problem is that she needs a mechanic to fix her car. Okay, so if we've all got this complicated system in place that prevents us from losing weight, why doesn't it also protect us from gaining weight and developing obesity in the first place? How can we explain the obesity epidemic? Getting back to Amanda, why did she develop obesity? The answer is that it takes a perfect storm to cause an obesity epidemic like the one we're seeing now. And it's our modern environment that places us, and Amanda, directly in the path of that storm. While there's no single cause for the rising rate of obesity, changes to the chemical and nutrient content of our food, the so-called Western diet, a decrease in physical activity, increased levels of stress, inadequate and disrupted sleep, and more widespread use of medications that promote weight gain all play a role. Our unique genetics and developmental histories cause each of us to respond differently to these elements of the modern environment, and some of us, like Amanda, respond by sending hormonal signals that elevate our set point for body fat. It's not that Amanda's system has stopped working, it's just that it's working to regulate her to a set point that's too high. So you can think of obesity as a biological response to the modern environment, a disease where the body dysregulates to a body fat set point that is too high. Back to our car analogy. The size of Amanda's gas tank has expanded, so she carries around too much fuel. So now that we've looked at one of the theories behind why obesity occurs, let's look at theories of how it occurs. It's often assumed that obesity in people like Amanda is a result of a massive imbalance to their energy balance equation, that their intake vastly exceeds their expenditure. But is this always the case? Consider this. If you're an average person, you consume about 900,000 calories per year. And it's true that you need to burn 900,000 calories to avoid gaining weight. If your energy balance were to be off by only 4,000 calories, an error term of less than 0.5%, you'd gain a pound every year. If you break that down, we're talking about a mismatch of 11 calories per day, the equivalent of approximately 2 potato chips. If your intake were to exceed your expenditure by just 40 calories per day, the equivalent of 1 pretzel rod, you'd gain about 150 pounds between age 25 and 65. So there are 2 points here. 1. If you're maintaining your weight, you're doing so because your body is matching your energy intake to your energy expenditure more precisely than you could ever do consciously. So it stands to reason that your system plays a role in doing it for you. And 2, people may gain weight not because their energy intake wildly exceeds their energy expenditure, but because of a very slight mismatch between the two. For Amanda to lose weight and keep it off, she needs to find a way to lower her set point. That is, rather than declaring war on her own biology, she needs to find a way to make her body regulate itself to a new, lower weight. One option for Amanda to consider is bariatric surgery. In study after study, it's been shown to be the most effective long-term treatment of obesity. But how bariatric surgery works is often misunderstood. Most people, even many doctors, think of bariatric surgery in terms of restriction or malabsorption. It's a reasonable assumption that surgery would work in these ways. After all, the procedures usually consist of some combination of altering stomach anatomy to be smaller, which you'd think would restrict the amount of food that you'd be able to eat, and rerouting the GI tract in a way that you'd think would make you fail to absorb the calories that you do eat. But new research suggests that certain types of bariatric surgery, for example, gastric bypass, sleeve gastrectomy, and duodenal switch, affect the signals between the brain and the body to decrease appetite, increase feelings of fullness, increase metabolism, and even encourage preferences for healthier food. Surgery may change the set point for body fat. It's like the anti-diet. Instead of fighting the set point like a diet does, surgery may recalibrate it, and the hormones that stimulate weight gain when a person diets do the exact opposite after surgery as the body regulates itself to the new lower set point. So here are 3 things you can take away from all of this. 1. Energy balance is complex and highly regulated. 2. Obesity is a disease where the complex system that regulates body fat may dysregulate to a set point that is too high. 3. Bariatric surgery may work by changing the signals that regulate body fat set point, enabling patients to successfully lose weight and keep it off.
As you can see, your genetic makeup and the environment we live in affects our weight dramatically. The purpose of today's class is to help you make a fully informed decision about which bariatric procedure to have. We hope and expect that you have been doing your own research up to this point. Many of you will already have a procedure in mind. Our goal is to be certain you choose your bariatric procedure for all the right reasons. We find that people often choose a certain procedure because someone they know had it done and did well with it. Some choose by looking at the pictures of the various procedures and base their decision on how safe or extreme it looks. These are, of course, all very valid things to consider when picking a procedure. But we want to be sure you are exposed to as many factors as possible, so when it comes time for surgery, you go in eyes wide open as to what you're doing and why. All of the bariatric surgeries work, but they don't all work for everyone. It is not our goal to push you toward or away from any particular procedure. We do them all and are happy to have you get any procedure which helps you safely meet your goals. Today, we will discuss the good sides and the bad side of each procedure and why some may be better for you based upon your behavior patterns or particular medical history. At the end of the day, people do best when they weigh all aspects of their behaviors, medical history, and characteristics of each procedure to make a final decision as to what procedure to ultimately have. In order to help you understand the outcomes of surgery, we need to discuss some terminology. Let's orient you to what's on this slide so we can use it as a backbone for our discussion regarding some terminology, and then use it to show differences in outcomes between the various bariatric surgery options. At the top is a large black arrow which represents weight loss or change in body mass index over time. Remember, body mass index is a math equation or ratio of your weight to height that insurance companies use to determine who qualifies for surgery. Typically, insurance companies cover surgery if your BMI is greater than 40 or if your BMI is greater than 35 with a weight-related medical condition or comorbidity such as diabetes, sleep apnea, high blood pressure, or high cholesterol. After surgery, both your weight and body mass index should go down. In this picture, the left side of the arrow represents your weight on the day of surgery, and as you move to the right, it represents time passing after surgery, where we would anticipate your weight will decrease. Below the arrow is an example patient labeled Patient A, represented by the black circle. The circle is located to the left of the arrow depicting weight loss over time. This is the initial weight and body mass index before surgery, which in this case is a weight of 300 pounds with a body mass index of 40 in a 6-foot-tall patient. After surgery, the weight begins to drop, represented by the circle moving along the timeline towards the right. If over time the patient loses 110 pounds, it would leave them weighing 190 pounds, representing a body mass index of 25. At a body mass index of 25, people are considered normal weight, or what has been termed the ideal body weight. The idea of ideal body weight was not created by doctors. It was actually created by life insurance companies in an attempt to determine risk of dying and how much to charge for life insurance as a result. They found people have the greatest life expectancy with a body mass index of 25. If your body mass index is either below 25 or above 25, then your life expectancy decreases. You might think that after surgery you will get to your ideal body weight. Unfortunately, most patients do not get to their ideal body weight after surgery. While not ideal, this typically doesn't bother most patients who often consider their ideal body weight to be too low for their personal goal. While each patient is different in how much they want to lose, it should be your goal to try to get to this weight if possible, because it lowers your risk of dying from obesity or obesity-related conditions as much as possible. If you don't know your ideal body weight, there are lots of options on the internet to help you calculate it. Here is an example of a common website that can help you calculate your ideal body weight. Another term you need to understand is percent excess weight loss. This is a somewhat confusing term, but understanding it is important because it's how your medical team will evaluate your weight loss after surgery and compare it to how others have done throughout the history of bariatric surgery. By comparing your weight loss to the many patients who have come before you will help you and us understand if you're on track to meet your goals. If you are not on track, we can determine what steps are necessary to help get you on track to meet your weight loss goals. We have a comprehensive program to help you meet your goals and are expanding the services we offer to patients in the post-op period who are not on track to meet and maintain their weight loss goals. In this example, we are going to use the glass of water to help understand percent excess weight loss. The water in the glass represents a patient's weight before weight loss surgery. Only a portion of the total weight, or a portion of the water in the glass, is the amount that equates to the ideal body weight. In this cartoon, the blue represents the portion of body weight, represented here by water, that makes up the ideal body weight. The remaining body weight, or water, represents the excess body weight represented by the red water. In order to get to your ideal body weight, you would need to lose all of this excess weight represented by the red water. However, as we previously stated, most patients don't lose all of their excess weight after surgery. There's typically some excess weight left over after weight loss surgery. After surgery, one of the mechanisms we will use to judge success is a term called percent excess weight loss. It is the percentage of excess weight above our ideal body weight that you lose. In our example, if you lost all of your excess weight, or all of the red water, it would represent 100% excess weight loss. As previously stated, after surgery, most patients don't lose all of their excess weight. If a patient was 100 pounds over their ideal body weight, and they lost 90 pounds, then they would have a 90% excess weight loss. This would mean the patient is still 10% over their ideal body weight. While there is no universally agreed upon answer to what is considered a success after surgery, most bariatric surgeons would like to see you lose at least 50% of your excess weight, or half of the red water. Each of the bariatric surgeries work differently, and each patient and their care team should select a particular procedure for a variety of reasons, including risks, goals, medical comorbidities, past compliance with medical treatments, barriers to access medical care, and psychological stability. When considering these factors, it's important to understand that each procedure varies in the typical range of percent excess weight loss that they achieve for most patients. Over the next few slides, we will explore this further. Here is an example patient who is 300 pounds and 6 feet tall. We will compare the average differences of each procedure for this particular patient. Each circle represents one of the weight loss procedures, and we will watch them move over time, simulating weight loss over time for this particular patient after the labeled weight loss procedures. We will compare them all to each other and to the topmost circle, which simulates a patient who achieves 100% excess weight loss, meaning they would have lost all of their excess weight, getting down to their ideal body weight, which in our glass of water example would represent loss of all of the red water. As you can see, after surgery, each procedure induces weight loss. However, there is an average range of weight loss typically achieved for each procedure. The range for each procedure is represented by two circles, one on the left, which represents the low end of the range of weight loss for that particular procedure, and the circle on the right represents the high end of weight loss range for that procedure. The line connecting the two circles may have different shades of black, which make the line. The darker portion of the line represents the region where more patients typically end up with that particular procedure. For example, after the lap band and the sleeve, patients tend to fall on the lower end of the weight loss spectrum depicted. You can see that none of the procedures typically get patients down to their ideal body weight, which would mean losing all of their excess weight. The duodenal switch is the procedure which on average gets the most weight off. You can see that none of the procedures typically get patients down to their ideal body weight, which would mean losing all of their excess weight. The duodenal switch is the procedure which on average gets the most weight off. You can see that the black line for the duodenal switch demonstrates that most patients lose on the higher end of weight loss. Many of you may be hearing about duodenal switch for the first time, and of course will get excited by the amount of weight loss. However, when you look across the country, duodenal switch represents only 0.6% of weight loss procedures being done across the country. We will be discussing this in more detail throughout the video. You can see that gastric bypass and sleeve both get off significant amounts of weight, but on average, not as much as the duodenal switch. The sleeve has a wider range of weight loss than the gastric bypass, with more patients on the lower end of weight loss. Finally, the lap band, which once was a very popular procedure, has the widest range, with the most patients falling on the lower end of weight loss. The wide range of outcomes and higher percentage on the lower end has resulted in a dramatic decrease in the number of lap bands being performed across the country. The lap band also differs from the other procedures in the speed with which the weight comes off. With the lap band, most patients don't lose their full amount of weight until about 5 years out from the surgery, which is preferable to some patients. This is in contrast to the sleeve, gastric bypass, and duodenal switch, where the majority of the weight is lost in the first 2 years after surgery. A concern with the lap band recently is that so few are being done across the country that it's becoming increasingly difficult to find surgeons who still do them and will be willing to help you with adjustments if you moved out of the immediate area. To many in the general public who haven't struggled with obesity themselves, they often think of surgery as the easy way out. However, there is nothing easy about weight loss surgery. In order to be successful, each patient must optimize their behaviors to maintain weight loss over time. Your surgery is very much like a tool that won't work unless you use it. However, your surgical tool can be a bit deceptive because with many of the procedures, weight loss in the first year or two after surgery comes off even if patients don't work hard at healthy behaviors. This results in initial weight loss, but early weight regain after 2 or 3 years out from the surgery. Consistent, healthy behaviors is the key to long-term success after surgery. Our team have a robust, lifelong follow-up plan for you after surgery, and it is mandatory that you continue to follow up for the rest of your life. It has been clearly demonstrated that patients who don't follow up are not as successful at maintaining consistent, healthy behaviors. In order to help you understand the effect of consistent, healthy behaviors after surgery, look at the colored bar at the bottom of the page. It represents behaviors after surgery, and the red side is patients not consistently maintaining healthy behaviors, and the blue side represents patients consistently maintaining healthy behaviors. Many patients who have finally made the difficult decision to pursue surgery get very motivated by the thought of having surgery and plan to work really hard to be on the upper end of the weight loss range for whatever procedure they choose. This is, of course, exactly what we want you to do. However, some may purposefully choose a procedure with a weight loss range lower than another, thinking that they will just work very hard with healthy behaviors and lose more weight than that is shown in the range for their given procedure. Unfortunately, it is not that simple. In this example, we see the weight loss range for sleeve gastrectomy. It is natural to think that you could just work really hard at consistent healthy behaviors and you will lose more weight, shown by the blue region, which extends beyond the typical weight loss range, to allow you to lose more of your excess weight and to get you to your ideal body weight. Unfortunately, the effect of consistent healthy behaviors is variable for each patient. If you look at patient B, the difference in weight loss is very small, no matter what their behaviors are like. However, you notice that they have lost over time significantly more weight than patient C, even if their behaviors are optimal. Our genetic makeup determines how significantly behaviors affect our weight. For some, the impact of behaviors is very large, and for others, it doesn't matter as much. We all have seen people who can make poor behavior choices, but don't put on weight. For those of you considering weight loss surgery, the combination of either behaviors or genetics or both has led to weight gain, which behaviors haven't been able to resolve over the long haul. After surgery, this changes to some extent for most patients. Surgery alters the set point described in the previous slides. The extent to which it changes varies from person to person, again based upon their genetic makeup. There will even be some after surgery who lose significant amounts of weight and maintain the weight loss, even without consistent healthy behaviors. However, this is not true for most patients. We cannot predict the extent to which behaviors will affect your weight loss, but it is one of the few things you can control and should be optimized to get the long-term weight loss and resolution of medical problems you desire. As mentioned earlier, though there is no universally agreed upon answer to what is considered a success after surgery, most bariatric surgeons would like to see you lose at least 50% of your excess weight, or half of the red water. The ranges we showed in the last few slides highlight the differences in amount of weight patients lose with each procedure. However, we also need to consider how well each procedure keeps the weight off over time. At 10 years out from weight loss surgery, there is a variation in the average number of patients considered successful after each procedure. As you can see, the gastric bypass is 80% successful at 10 years after surgery in those whose body mass index starts below 50 prior to weight loss surgery. In those whose body mass index start above 50, the success rate drops to 60% at 10 years after surgery. In comparison, the duodenal switch is 94% successful at 10 years. The sleeve gastrectomy has not been around long enough to give us reliable 10-year data, but in a recent consensus paper published by the American Society of Metabolic and Bariatric Surgery, it seems to be less successful than the gastric bypass at all time points beyond 1 year out from surgery. It is important to note that obesity is a chronic disease. Like all chronic diseases, patients will be fighting them for their entire life. Surgery is the best option currently available for long-term weight loss, but you will continue to battle it forever. Some patients after surgery need to undergo additional surgeries over time to increase the amount of weight lost or to induce loss of weight that was regained over time after surgery. Clearly, before we consider any additional surgery, we will want to optimize healthy behaviors and attempt all reasonable medical options available to help sustain and induce weight loss. The sleeve gastrectomy is the most commonly performed procedure around the world currently. It involves stapling and permanently removing a portion of the stomach. The end result turns the stomach into a thin tube resembling a banana shape. It has grown rapidly in popularity for several reasons, including it's relatively quick and easy to perform in experienced hands. It doesn't induce much dumping syndrome like the gastric bypass, and the weight loss is similar to but slightly less than the gastric bypass. Since it appears in the picture simpler than some of the other procedures, many patients assume that this means it's safer. It is true that it has less risk of internal hernias and ulcers that can occur with some of the other procedures. But the risk of leakage and pulmonary embolisms is the same as the other procedures. In the rare chance you get a leak after a sleeve gastrectomy, which in the literature occurs somewhere between 1 to 3% of the time, it is more difficult to treat than after a gastric bypass. One special consideration after sleeve gastrectomy is acid reflux. The world data regarding acid reflux after sleeve gastrectomy is confusing to say the least. We know some patients will have pre-existing acid reflux go away, and for some it will get worse. We know that somewhere around 10% of people who did not have acid reflux before surgery will get it as a result of their sleeve gastrectomy. A small number of these patients who get new onset acid reflux after sleeve gastrectomy will require another surgery like conversion to a gastric bypass to control the acid reflux. Patients with moderate-sized or larger hiatal hernias, a condition where the stomach pushes up into the chest from a hole in the diaphragm, may be at increased risk for acid reflux after sleeve gastrectomy. In contrast to the sleeve gastrectomy, the duodenal switch is the least commonly performed weight loss procedure around the world. While duodenal switch has been around since the 1970s, it is only fairly recently that it could be safely performed laparoscopically. Many weight loss surgeons out there have not been trained to do the duodenal switch currently, but to many it is considered the most drastic of the weight loss procedures. In the video, you can see that a portion of the stomach is removed in the duodenal switch, exactly the same way as the sleeve gastrectomy. However, it also includes bypassing a portion of the intestine. When bypassing a portion of intestine, you may not absorb nutrients as well as you would otherwise. In comparison to the gastric bypass, which will be described next and also bypasses some of the intestine, the duodenal switch bypasses a significantly greater portion of the small intestine. By bypassing large amounts of the small intestine, it means more weight loss, but it also makes it prone to some issues. These issues can typically be avoided by regular follow-ups, as is expected after all of the procedures. However, after duodenal switch, those who don't follow the recommended treatment guideline can end up with some serious complications. These can include severe vitamin deficiencies and malnutrition, which can be permanent if ignored for a long period of time. On the internet, patients will often read relatively disturbing reports about diarrhea and foul-smelling gas in regards to the duodenal switch. While in some cases this is true, it's typically something you as a patient can control. If you don't follow the recommended dietary guidelines, patients may experience loose bowel movements, but this typically doesn't occur regularly if dietary guidelines are followed. With all of the weight loss procedures, there is a good chance that there will be some changes in your bowel habits. With sleeve gastrectomy and gastric bypass, patients tend to be more constipated, which can occasionally lead to abdominal pain or require a daily stool softener. Duodenal switch patients may have increased bowel movements, on average 2 to 3 bowel movements per day. The gastric bypass was the most common weight loss procedure performed across the world until recently, when it was overtaken in popularity by the sleeve gastrectomy. It consists of stapling the stomach into 2 pieces, with none of the pieces actually being removed from the body. Both continue to perform their natural functions. However, the food is routed through a small stomach pouch, which is made to be about the size of an egg. In order for this stapled stomach to drain and allow food to exit the stomach pouch, the small intestine is rerouted, bypassing a portion of the intestine. This bypass is similar to that seen in the duodenal switch, but much less small intestine is bypassed. The remaining stomach, known as the gastric remnant, remains in place and continues to make gastric juices required to help with nutrient absorption. In patients with known acid reflux, the gastric bypass is the best procedure to treat reflux. However, with gastric bypass, about 4% of patients will get what is known as a marginal ulcer. This is a small ulcer which forms near the small stomach pouch on the small bowel side. This can lead to pain and difficulty eating. While rare, it occurs much more commonly in people who smoke, take oral steroid medications, or non-steroidal anti-inflammatory medications. The non-steroidal anti-inflammatory medications include aspirin, Motrin, ibuprofen, Advil, Aleve, Goody powder, BC powder, Mobic, diclofenac, and many more. We will work to find you alternatives to these medications for use after surgery. You will be able to take Tylenol after surgery. The risk of marginal ulcer is only associated with the gastric bypass. You are able to continue taking nonsteroidal anti-inflammatory medications after having the sleeve or duodenal switch. Here, we are comparing the bypassing of the intestine in both the duodenal switch and the gastric bypass. As previously stated, but not well demonstrated by our video, more intestine is bypassed by the duodenal switch than the gastric bypass. Both reconstruct the bypassed intestine with a Y configuration. Food comes down one portion of the Y, digestive juices come down another arm of the Y, and they meet and mix further down after a small bowel connection. The mixture of food and digestive juices are required for absorption of nutrients to occur. The portion of the small intestine which is brought up to attach to the stomach is known as the roux limb. You can see that it attaches at slightly different places for the gastric bypass and the duodenal switch. In the duodenal switch, it attaches just after the stomach, which leaves intact a muscle at the end of the stomach known as the pylorus. You can see in the gastric bypass, this is bypassed. This muscle serves a few functions. It helps prevent marginal ulcers described in the last slide. It also prevents something called dumping syndrome. Dumping syndrome is not nearly as common after sleeve gastrectomy or duodenal switch because the pylorus has not been bypassed like it is in the gastric bypass. What is dumping syndrome? When patients eat meals high in fats, sugars, or foods that easily get converted to sugars, such as carbohydrates, they will often experience an uncomfortable sensation that can be different for each person. It can include abdominal pain, nausea, vomiting, a hot flushed feeling, or feeling like your heart is racing. It typically will last for 30 minutes to an hour before it goes away. Some would argue that they don't want to have a procedure that can cause dumping syndrome. However, many patients depend on it to keep them away from these types of food because they are their weaknesses. If you eat a sugary food that causes dumping syndrome and it in turn makes you feel bad, then the next time you encounter that food, it makes it less appealing to you. Another issue shared with both gastric bypass and duodenal switch is the issue of internal hernias. When the small intestine is cut or divided to bypass a portion of it, there is an opening below the bowel where you can form a hernia. This space is sewn shut by what is sewn together is fat, which after surgery melts away with weight loss and potentially leaving an opening known as an internal hernia, where bowel could get trapped and possibly require more surgery to fix. We have covered a lot of information today. Our hope is that you have done research in advance of today's meeting, which led you to be thinking about one or several of the weight loss procedures. Hopefully, today has helped round out your thinking about the procedures. However, patients often struggle with how to put all of this information together. That is, of course, what we are here to help you with and will be discussing in your individual assessment. Here are things we will consider when thinking about your weight loss options. Number 1, we will want to assess your weight loss goals. If your goals are not in line with the ranges described for the procedure of choice, you may want to reconsider. Also, it's not just how much you get off, but how likely you are to keep it off. Number 2, we will want to consider your specific medical history and how that may be affected by your procedure choices. We discussed acid reflux in detail with the controversies around sleeve gastrectomy and that gastric bypass is the best at alleviating acid reflux. Diabetes is a common reason patients seek out weight loss surgery. All of the procedures help resolve diabetes, but some do it better than others. Duodenal switch does the best at getting rid of diabetes, and the sleeve is the least effective. If you are a new onset diabetic not on insulin, the sleeve may be enough to make your diabetes go away. However, Patients who have had diabetes for over 5 years or are on insulin likely won't see diabetes go away unless they have a more aggressive procedure like the gastric bypass or duodenal switch. Number 3 is the current state of your abdomen in relation to scar tissue from previous procedure. For example, if you have previous incisions from other surgeries, it will create scar tissue that could make some or all of the weight loss surgeries impossible. A common scenario is someone who has a large midline incision from another procedure who wants a gastric bypass where a portion of the stomach has to be pulled up to the stomach pouch. If the small intestine is stuck in scar tissue, it may be safer to perform the sleeve gastrectomy, which doesn't require manipulation of the small bowel rather than an opening up and doing surgery the old-fashioned way with an open incision. If this scenario is relevant to you, it's important to have discussed a backup strategy if your surgeon attempts to do your operation of choice and finds it can't be done because of scar tissue. Number 4 is risk factors for marginal ulcers. If you require the non-steroidal anti-inflammatory medications, you may want to consider something other than the gastric bypass, which can be prone to ulcers. This is also relevant to smokers. We require all patients to stop smoking prior to bariatric surgery because it increases risk of post-operative complications. This is also a time to initiate consistent, healthy behaviors, and smoking is not one of them. Unfortunately, relapsing back into smoking is more common than we like, so if you have been a long-term smoker, you will need to quit for surgery, but likely should consider something other than gastric bypass due to the ulcer risk. Number 5 is your compliance with health behaviors and medical care. If you have never been good about taking your medications or doing what your doctor recommends, it's unlikely you will improve dramatically in the long run. If this is the case, and you don't take your vitamins or get blood work checked after surgery, it can put you at risk of permanent damage with any of the procedures, especially with the duodenal switch. This should be considered when deciding if you have surgery at all and which procedure you choose. After Group Today, you will have an individual assessment with our team. We will take what we discussed in Group Today and put it in context with your individual medical history to help make sure it makes sense with your goals. At the conclusion of today's meeting, we will give you a list of the medical tests and appointments we will need to complete to get you to surgery in the safest manner possible. For all patients, it includes the items on this list. Several of these tests can be completed today after you leave clinic at Duke Regional Hospital Outpatient Center or Duke Raleigh Outpatient Center. If testing reveals any abnormalities, you may require further testing or treatment to get you ready for surgery. If you have significant medical problems, we may require you to get a clearance from a specialist in that particular disease process. I would suggest you delay final decision about specific procedure choice until after your endoscopy. This is a test which will require you to be sedated and for your surgeon to run a camera down through your mouth into your stomach to assess the anatomy. There may be things we see on an endoscopy that affect which procedure we would recommend you have. We hope you have enjoyed today's new patient visit. We are here to help you on your journey to and from weight loss surgery. The quickest way to reach us is through a MyChart message addressed to your surgeon.